So, our topic tonight, as you know, is all about HR1, the one big, beautiful, ugly bill, and what it does to healthcare. So, we've got our presentation ready. As I said, we're going to bring more people in the room. I invite you all to introduce each other or introduce yourselves in the chat. And very shortly, we will be good to go. And I love all you early birds who are here even before 8 o'clock. Oh, I see. Whoa, I see a lot of people that I know that are joining us. So, welcome to our One Big Beautiful Bill and HR1. That is going to be our topic tonight, what it does to healthcare. Basically, in a word, it makes an absolute mess out of it. And again, it's really sad when you make a mess out of a system that really isn't a system and was already kind of sort of a mess anyway. So, welcome. It is just 8 o'clock. So, let me get these reading notes out of here. All right. We will be recording this. So, everyone who is registered, you will get a copy of the recording. You will also get a copy of the presentation, or at least my presentation. I'm going to be happy to provide that. We will check with Dr. Sharma, and if she's happy to provide her presentation, we will provide that for you too, so that all of our activists on this call may continue being activists. So again, thank you all for arriving early. It is 8 o'clock and we already have 45 people in the room. This is going to be good. Oh my goodness. We've got people from North Dakota. That's not a state we see all that often. We see a lot of people from California, Maryland, Virginia, North Dakota. We're feeling honored. Thank you so much for joining us. All right. I'm Andrea Miller. I'm the founding board member and the executive director of Center for Common Ground. And I have the distinct pleasure of opening up this meeting. And I see we have some North Carolina people, specifically from the North Carolina Poor People's Campaign. Welcome. We are delighted to have you with us. All right. I am only going to continue randomly speaking at you. And I promise you, when you get the video, we will excise this part and we will actually start at the very beginning. But we've learned we always want to make sure we have the whole presentation. So we record from the very beginning. All right, only one more minute to go, and I'm so excited people are still joining us. This is great. Now we've got more than 200 people registered, so that's why I want to get as many in the room as possible before we get started, so that we will hopefully not have too many redundant questions. All right. And again, more old friends. Old meaning I've known them for a while, not that they're quote old. People are like, why are you always saying we're old? I'm not saying you're old. I'm saying I've known you a long time. You're very dear. I'll say dear friends. How's that? I won't say old. All right, we are going to literally get started in just a moment. So I will reintroduce myself and we will get going. So, good evening, everyone. I'm Andrea Miller. I'm the founding board member and the executive director of Center for Common Ground. Thank you so very, very much for joining us. Several years ago, when I was lobbying on Capitol Hill, one of my specialties became the federal budget. So it was very, very interesting to get back to looking at the budget literally in 2025. So one of the things that I work on putting together, and then Ed Juan worked with me to expand it, is information about the current federal budget that was passed in July. And specifically tonight, we're going to be focusing on what it does for healthcare. Next slide, please. Now, this bill is perhaps one of the largest transfers of wealth from the middle class and the poor to the billionaires. So when we look at the overall impact of this budget, $24.8 billion in total tax savings went to the top 1% of Americans by income. As Bernie Sanders is always saying, the billionaires. Well, there are 813 billionaires in America. I was shocked. I was surprised there were that many. So with 813 billionaires sharing $24.8 billion, that's roughly $30 million per person. Now, this next number really shocked me. We have 24 million millionaires in the US. That's the top 10%. So now we're literally looking at the top 11% of the population. They are sharing roughly $37 billion. Now, the rest of us, all 342 million of us, we're sharing $6 billion. Now, there are a lot of people who are getting absolutely nothing. But if we were sharing this equally, then we'd be getting $16.50. All right, next slide. Now, how did they come up with all this money to give to the billionaires? Basically, they stole our health care, they stole our food, and they stole our education. So, as I said, tonight we're going to focus in on healthcare. There are a number of resources and links that are going to be available to you in this presentation so that you can dive a little deeper into what happened in your own state. So the cuts to SNAP, that's food stamps, Medicaid, and the Affordable Care Act came out to about $1.3 trillion. So when we look at Medicaid, roughly 11 million people are probably going to lose their Medicaid. Now, even if they don't lose their Medicaid, there will be a lot more that people have to do to remain qualified to get it. 5 million people are probably going to lose their ACA coverage. And you may hear that on Capitol Hill, they are fighting to restore the ACA subsidies. If they do not restore these subsidies, 5 million people are basically not going to be able to afford health insurance, because in America, health insurance and health care are very tightly related, even though realistically they're not the same thing. Now, if you are a dual eligible, meaning you are a senior, a low income senior, or disabled, you may be a dual eligible, meaning you receive Medicaid and you receive Medicare. Part of the Medicaid cut is that Part B will no longer be paid by Medicaid. Now, the decent thing, at least in theory, is that it limits provider taxes, which in theory increase Medicaid payments to hospitals, nursing homes, and other private managed care providers. So that remains to be seen how that works. Edwan will go into those details a little bit more. Next slide. Now, if you are on Medicaid right now, or previously it was free to see a doctor, Medicaid enrollees, people that are already low income, they will be paying $35 to see a doctor. This will not apply to mental health primary care or substance abuse treatment. So that also means there will be a higher cost for emergency room treatment for non-emergency cases. Immigrants are potentially going to lose their ACA coverage, refugees, asylum seekers, victims of trafficking, and as we have already seen with ICE, there are people who are lawfully present. They will potentially lose their ACA coverage as well. Next slide. One of the biggest and the worst cuts to medicine on the education side is that people who are pursuing a medical degree, their student loans, their grants, they are capped at $200,000. And I have a very dear friend who's a medical doctor. And the moment she saw that, her question was, where are people getting these medical degrees for $200,000? Not in the United States. So in a scenario where we are potentially closing hospitals, we are simultaneously making it more difficult for working class people to become doctors. Next slide. In Virginia, and I'm using this as an example, the loss of the ACA subsidies took a family currently paying $749 a month for health insurance. And that means they were doing reasonably well if that was their payment. Their new payment is now $2,092 a month, or basically a $1,342 increase. And again, with the loss of federal jobs, with general job loss, so many organizations laying off people, Amazon, all the bad people, they're all doing layoffs. And many of the layoffs are not their drivers, they are their middle managers. This becomes something totally impossible to manage. Next slide. This is a sample of what you will find when you follow our links and look at what is going on in your own state in terms of how is healthcare provided. So the first slide, Virginia, it shows that they're the biggest provider of healthcare our employers. But then we have Medicaid, Medicare, the uninsured, ACA, the states that expanded Medicaid, CHIP, Children's Health Insurance Program, and the dual enrollees that I mentioned a moment ago. The hardest hit people are going to be Medicaid, ACA, Medicaid expansion, and dual enrollees. All right, next slide. I'm also showing you Georgia. Georgia did not expand Medicaid. Their Medicaid expansion is 0. And then I also showed, next slide, California. So again, when you look at California, the numbers are even bigger. So on your own, when you get this presentation, there are individual links for all 50 states where you can go and take a look statewide. What is your healthcare mix? And it is even broken down all the way to congressional district. So you can get a feeling of who is being hurt and where is it coming from. Next slide. As rural hospitals close, more people are going to be forced to travel to urban hospitals. Also, 75% of seniors in nursing homes have their care paid for by Medicaid. So family members are now going to have to take care of these seniors. As lower income working people lose Medicaid assistance paying for ACA and drop coverage altogether, healthcare premiums will rise for everyone. And that happened in January. So as soon as the health insurance companies found out that these subsidies were not going to be continued, literally all of them raised their rates for January of 2026. And then, as I mentioned before, if you are a senior or disabled dual eligible, Medicaid will no longer pay for your Part B. Your Medicare Part B is all the medical services not administered inside a hospital setting. So your doctor visit, your test, if you have Medicare Advantage, your dental, your vision, and your hearing aid coverage. All right, now, next slide. Let's take a look at the hospital closings and what states can begin to look at to mitigate the cuts. So I want to introduce you to our new public policy director, Edwin Whitehead. He joined us in officially as the public policy director in December of
Yeah,
2020.
that was my Christmas gift. Thank you very much, Andrea.
And he has been very, very busy working on state and local policy strategies. He has prepared the necessary legislative packages for all 50 states. We'll tell you where you can find that on the website. He has been amazing in the Virginia General Assembly, working with new members and experienced members to either introduce or amend existing legislation. So I give you Edwin Whitehead.
Thanks, Andrea. I appreciate that amazing introduction. Good evening, y'all. I'm really glad all of you are here to kind of walk through some of the things that we've been looking at. The bigger thing for me, just looking at HR1 from an overall standpoint, is that you have to understand that not a single state, not one, out of all 50 states and the territories that are amongst this country, not a single solitary one is going to go out of this unscathed. Everyone is going to feel the blowbacks of what this is going to look like unless we start trying to navigate away from that now. And so, some to kind of expand on some of the healthcare impacts that Andrea was talking about. Um, the bigger thing is kind of just looking at the overall. It reduces the reducing of coverage and the provider funding not being there, coverage losses, administrative barriers, funding constraints. There's going to be a lot fewer people insured. There's going to be a lot of uncompensated care, which we have a lot of already. And we're going to see a lot of service cuts and a lot of closures because of it. And so, just looking at some of the coverage losses, wanted to go over some data points around that. The CBO is projecting that this will increase people without insurance to about 10 million by 2034. I know someone was asking about where that money, what the money cuts are going to look like. So between now and the sunset clause of HR 1 is, I want to say it's 2030, 2032. But the blowback from what that'll look like going into those fiscal years, anytime after that, will be long lasting. And so the independent analysis is actually estimating that anywhere between 9.9 to about 14.9 million people are at risk of either losing their Medicaid coverage or their ACA coverage altogether under the final legislation because of the eligibility, the work verification, or a lot of the verification provisions. So getting your paperwork in, showing your income, those kind of things like that. And so, this really isn't theoretical at all. The coverage losses are definitely a math problem for everybody and definitely a math problem for hospitals because fewer insured patients means more uncompensated care and much more weaker margins, and it means people are going to die, and we don't want that. That's what we try and navigate getting away from, right? Um, the administrative barriers they've been trying to change have been work requirements and verification provisions that don't just affect people who aren't eligible. They also cause folks who are eligible to lose their coverage because of paperwork and like because of the real world pattern of like losing mail or them not getting a certain piece of paper in time or not reporting your income on time or what have you. And so it provides a lot of those kind of barriers. And it also includes a 10-year delay to 2034 of parts of two Medicaid eligibility rules, which is meant to reduce administrative burdens and improve retention. So meaning that states and beneficiaries will face more friction for a longer period of time. And so when we're looking at 10, they put this into a game plan of 10 years, y'all. And the policy impact of all of this at this point is not only about who qualifies, but who can also stay enrolled. Because that's going to always be the benefiting factor there. Rural impacts around this. I think the AHA was estimating that HR 1 would lead to about 1.8 billion people in rural communities losing some level of Medicaid coverage by 2034, and about $50.4 billion reduction in federal Medicaid spending on rural hospitals overall over the next 10 years under these provisions. And so we're going to see a lot of folks in rural areas, a lot of areas where a lot of these folks were getting voted into office from, to be honest, are going to start really feeling the blowbacks of what this is going to look like because the decisions people that they put in their office are making now. And so across the board, I want to say KFF had the best numbers on this. KFF estimated that $50 billion in the rural health fund is an offset. So literally 37% of the estimated rural Medicaid spending cuts equals about 137 billion. And so we're not even trying to play ball when we're talking about keeping up with it funding wise. And even the remedy or mechanism that's been put in place by the federal government, which is the Rural Health Fund, is not feasible. It's not even covering 37% of the actual cost it's going to take. And just rural areas. That's not counting all the urban areas that it covers as well. And so, I think that when we're talking about actual impacts just for harm outside of the metros and things like that, we're looking at losing tens of billions of dollars and hundreds of facilities, pretty much being at risk here at this point. And the rural fund is not going to facilitate helping with that at all. So how do I describe this? When we talk about margin collapses, hospitals don't usually shut down overnight. So when we cut services that are meaningful for people, so things like OBGYNs, behavioral health, dialysis, and we only, even to an extent, ER staffing is a part of that for certain triages or things like that. So limiting those staffs as well. And so we will see a major collapse in rural areas, especially. When we're looking at this map, it's saturated in yellow. It's a lot of people at risk. There's already facilities that have been closed, and there are literally that number is growing every single solitary day. The number of people losing healthcare is expanding every single solitary day by the hundreds. And so the access impact of HR1 is not just about the insurance card situation. It's really whether our a county or this country can really have a hospital that can actually deliver babies, because that's what it comes back to, right? Like having the basic bare necessities that we need to be able to survive with some level of dignity. And so I'll turn it back over to you, Andrea. I really want to. I don't like talking about the problem too much. You know me. I like talking about solutions.
The solutions. All right. Thank you, Edwan. Edwan will be back. John, you can drop the slides. I want to introduce a very, very dear friend of mine. Chuck, you and I met way back in 2010 when I was in Pennsylvania for a Medicare for the event. Anyway, Chuck Pinocchio, PhD. I never knew you had a PhD. You hit that for me, Chuck. He's a historian, a strategist. I know Chuck as a strategist, a union organizer, healthcare reform leader, writer, and a filmmaker. So again, if you absolutely want to read Chuck's whole biography, I will put it in the chat. Otherwise, I want to let Chuck talk to you about his current endeavor and how he is working to resolve the root cause of America's healthcare mess. Chuck, take it away.
Thanks so much, Andrea, and I really appreciated your overview, and it's really been great just for even the short time Edwan's been with you, working with him. He's a real gem, and also a shout out to John and Gabriel for being support tonight. Really, you've got such a great team. Should be proud of it, and everybody in the room pile in and just keep supporting the work Center for Common Ground is doing. It is so vital, so very important, so critical especially at this time of crisis that we're fighting through. So again, Andrea, thank you so much, and I'm also looking forward to Dr. Sharma's comments, very much so. And Jessica, I think your colleague is in the room, so love to hear comments as well. So I'm going to be pretty brief. Can I have co-host, right? Can I just share?
You are co-host.
Oh, okay. So I'm gonna just share. It's a Word document that I should just tell you folks that today was my move day. It's really hard to do these when you're actually moving from Michigan to DC. However, here we are. I've got the Word doc, and I'm happy to share it too. So my stuff is open source. Let's see. Do I have that sharing?
Yeah, you do. Bottom of the screen, green share button.
Yeah, I got that, and then it comes up kind of. It does. Let's see, documents maybe.
Yeah, pick the screen. Pick this once you pull it up. Pick the screen that you wanted to share.
Okay, so I guess documents, is that right? Yeah.
Yep.
I don't know.
Sorry. Oh, okay, then I'll do that. Share.
Okay.
Oh dear. That
I've
wasn't.
got it. So
It should also be under screens if you have it open.
Yeah, I emailed it to you, Andrew, and to
I've
Josie.
got it.
Okay.
I've
I'm
got
so
it.
sorry. Yeah. I've been scrambling just to get to this point today.
Exactly.
Thanks
All
everybody for your
I mean,
indulgence.
moving
Let
from
me get
Michigan to
this thing
DC in the middle of winter
open.
is not ideal.
And Loday's in the room. Yep.
Yes.
You're
He is. All righty. We go. I got it. I'm ready.
okay. Thank you.
We are.
So we can increase the size a little bit, possibly. There we go. Yeah. And then in my revised form, the revised version of this will have my websites and a little bit more. But yeah, just in talking with Edwin and Andrea the other day, the question is, what can the states do right now? There's a lot that the states can do. And so I reached out to my brain trust, including Dr. Walter Tsu. Many of you know him, former health commissioner of Philadelphia, former president of the American Public Health Association, and he has come around foursquare in supporting what we call SABUCA. This is the State-Based Universal Healthcare Act. This is enabling legislation that's been around for 15 years. First, Jim McDermott had it, then Pramila Jayapal, now Ro Khanna, and recently we brought Ed Markey in to support this on the Senate side. And just to read Walter's comment here, he says the value of that bill, the SABUCA bill, is it's centered on single payer healthcare. And that the one payer plan, as we alternately call it, single payer, one payer, offers its residents an alternative funder that would make up for the Medicaid and Medicare losses. Without such a plan, Medicaid especially would be unable to pay its bills. And I'm just going to add to what Walter's insight is that this legislation, it's the bill numbers are right there, HR 4406 S 2286. It's enabling legislation. It's designed to allow states to bring the federal healthcare dollars back into the states to make a more robust financial system. 50 to 70% of each state's healthcare dollars are paid out to the federal government. That's Medicare, that's Medicaid, CHIPS, federal employees, TRICARE. Andrea referenced those in her opening comment. Those monies can be actually brought back into the state and create a single pool. That's what single payer is, a one payer pool that streamlines the way that money is handled in terms of paying for healthcare. This is where you make up anywhere from 15 to 25 up to 35% of administrative waste, fraud, abuse, waste, excessive profits, commercials, advertising, all that stuff is just flushed. About a third of every healthcare dollar is flushed through these gross inefficiencies and corruption. Single payer would get us back in the game where our administrative overhead would be somewhere in the neighborhood of 3%, somewhat comparable right to Medicare. Medicare for all is another way of saying national single payer. The states have the opportunity to model this success, much as Canada was able to do with Saskatchewan before they went national. This is the way that so many reforms have happened in this country, state modeling. So the idea here is to create this funding system, but also to give a legal waiver. It's called ERISA, the Employee Retirement Income Security Act. And that waiver is also critical because it'll insulate the states from being sued by these private self-insuring companies and other right-wing interests who are hostile to all kinds of public health care. Politically, also, I have to say, having lobbied on Capitol Hill directly the last 2 years and lobbied in Harrisburg for 5 years when I was the head of Healthcare for All PA, we know how to talk to conservatives. We know how to lay out the fiscally conservative argument for this kind of legislation. And so I really, truly believe that this bill, the SABUCA bill, has a real chance of passing once we get past the current fascist insanity. This is something that will allow members in the middle and the right to make amends to their constituents that they've neglected and treated poorly over the last several years. But the challenge is that the national bill, going straight to a national bill, is problematic because right now we have about half the Democratic caucus, that's 25% of the total, 15 members of the Senate, that's 15%, are on board with the national bill. I really believe, as somebody who ran on national single payer when I ran for U.S. Senate 20 years ago in Pennsylvania, that the way we're going to get there most likely is through the states. And the other thing to be aware of is that the money in politics. Everybody's generally aware of this, but I identify what I call the four horsemen from hell. And this is big insurance, big pharma, big hospitals, and big medical device and supply manufacturers. And many of these members of Congress are lining themselves up to be lobbyists for those very organizations and industries. So there's so much complicity, there's so much corruption that's in the system. It's very difficult to go forward. I'm going to be real brief. Let's just touch on Chris Curry's has a series of bills that he shared with us in Washington State. And I'm limited on time tonight. So I'm just going to say that these bills are designed to create an excise tax on large corporations, tax employers who don't offer health insurance, tax pharmacy benefit managers, this PBM problem. If folks aren't familiar with it, check it out. It's really an important problem in healthcare, where they insert themselves between the patient and the pharmacist, and they make money on both ends. It's absolute corruption, the PBMs. Also, another bill would establish a data broker registry for the purpose of taxing their businesses, and also remove the tax exemption for the replacement of equipment for data centers. Keep scrolling, and then I want to get to some of Loday's stuff down here below. And also, another bill would eliminate these MCOs, these managed care organizations, which are corrupting the whole system as well. Loday gave a really brilliant summary of the work that she's doing. Loday, if you don't know her, she's part of the Center for Common Ground team, a master herbalist, indigenous direct entry midwife. Is in Georgia as working with Center for Common Ground, and then one of your democracy centers. So just bullet points here. Use state authority to stabilize coverage when federal backstops are withdrawn. Replace fragmented privatized care with a unified public financing model. Keep scrolling. Protect seniors with disabilities, low-income residents from benefit erosion. And she's describing how you do that. Of course, I can't get into it right now. Strengthen state fiscal predictability and negotiating power, and preserve healthcare as a public good rather than a profit center. So really brilliant stuff. Loday, and a shout out to Chris Curry and Walter too for helping me with this presentation. I hope this is a good start, Andrea, for what we need to get done tonight. Thank you so much.
Certainly is, and I will be more than happy to put that in presentation format for you. So very, very happy to do that. So what I'd like to do now is I want to introduce you to a new organization that we really didn't know about them, but we're very excited to discover them. The Civic Health, wait a minute, Civic Health Alliance. There we go. It was like, I knew what it was. And we have a speaker from them, Dr. Manisha Sharman, who will talk to you about what this organization is doing. And they are playing a very important role from inside the medical and the healthcare community. So, Dr. Sharma, the floor is yours. I believe you have a presentation. Thank you, Jessica.
Hi there. Thank you so much for allowing us to be with you tonight. I just want to say thank you to the other speakers, because I think all of what you've brought to the table is really important for folks to understand. So my name is Dr. Manisha Sharma. By training, I am a social medicine, family medicine physician, and I'm the co-founder of Civic Health Alliance. We are a nonprofit organization that is nonpartisan and really thinking about how we look at civic engagement as a healthcare maintenance, if you will, and really being thoughtful about why it's important to look at civic health and your civic engagement as part of your healthcare picture. We really advocate for America's health through civic engagement and teaching our patients as well as our colleagues over why it matters to have your voice heard. A lot of the work that I do is really working at intersectional work between policy and care delivery and social justice. And so civic engagement sort of touches all of those things. We are focused on why and how civic engagement actually makes your health better. We know by data that wealthier communities tend to be healthier and they tend to vote more. So it should not surprise us to say that things are shifting in a way that really benefit those who are with versus those who are without. And we are wanting to uplift our communities by being with our communities, for our communities, and by our communities, by helping them see and being a part of being able to navigate them towards getting their voice heard through voting. So when you go to the doctor, for instance, a lot of times they'll ask you questions such as, do you smoke? Do you wear a seatbelt? We also ask and we train folks to think through, have you registered to vote? And talk to them about why that matters to their health and why it matters to their families and their community's health. And so that's the work that we do sort of on a higher level. I think it's really important. I really love Chuck's presentation in regards to single payer. I'm in California. I'm also a single payer believer. And I do agree that this is really our opportunity for all of this craziness that's happening in our country that is assaulting healthcare and healthcare workers and patients in our communities. Single payer is the way where we have an opportunity to really be thoughtful about how we can have communities not just barely survive, but really get them to thrive. And so, this is our opportunity to really center that where we are. Next slide, please. There we go. So we are running a campaign on really thinking about what we call the 1,000 Caring Voices campaign, where we are wanting to find healthcare colleagues to be champions on getting folks to train them on how to talk to patients about voter registration, but also getting our healthcare workers to understand that their voice matters now more than ever. HR 1 is affecting healthcare workers on so many levels. I think the first one that I really want to say, as I am a practicing physician in the community, is that, when our patients suffer, we do as well, because we feel at a loss that we cannot help. And when people tend to be sicker and we're just trying to make sure that they don't die, or they are not get sicker, more sick than what they are now, that is moral injury for us. It does not make us. We went into this career in being in healthcare to care for our communities, and this is really what it's doing is affecting us on burnout. It is affecting us on shortages and just feeling helpless. And so what we really want with this campaign is to really to say to our colleagues, we see you, we hear you, to say to our patients, we see you and we hear you, and training our colleagues to actually start talking to each other and start talking to patients about why their voice matters. I think the election in New York is a really great example about how movement work can happen when we talk to each other about why civic engagement matters. And this is something that we can do. And we have that opportunity within healthcare settings to be able to get people to understand that their voice can be and should be heard through civic engagement. And so we are hoping that folks who are on this call, who are healthcare workers, believe in healthcare, love healthcare, could be part of our campaign on 1,000 Caring Voices. Next slide, please. And there's ways for you to join by this QR code. Part of what we can do with this, this campaign is also create very nuanced and focused ways to create toolkits for you where you are, and being able to address it towards the state and the state regulations in terms of voter registration, and then really being able to give folks, next slide, please, how you can use the law that already exists that actually says that this is a responsibility that we should be doing into healthcare settings, and that this law exists still to this day. And it is, again, registering people to vote is a nonpartisan act. If you receive government-based dollars, this is a way then you have an obligation to register people to vote. And so most hospital settings and FQHC settings tend to take Medicare and Medicaid dollars. And so it behooves them to actually create registering to vote sort of campaigns and movements within their spaces in their brick and mortar. So we are happy to share that information. We're happy to help you think through how to do this where you are. Just give us a call and contact us, and we would love for you to be part of our campaign.
Thank you very, very much. I'm going to add something because we work with BIPOC voters. We work with voters who, you use the word, are underrepresented. So what we have learned to say is not, are you registered to vote, but is your registration up to date? Because we found far too many people telling us they were registered because at one point in time they were. But we are now seeing again robust efforts to kick people off the voter roll. In Wisconsin, we were planning on sending postcards to 190,000 registered Black voters in the city of Milwaukee. When we got the list, it turned out only 86,000 of the 190,000 were still registered. They had been dumped off the voting rolls. People just don't understand that in voter suppression states, not voting as often as people think you should gives them a legal reason to dump you off the voting rolls.
Yeah, I mean, a lot of our work is also that, but a lot of the engagement is, are you registered to vote? And then it's like, oh, you did vote. Well, let's check on what your status looks like.
Yes.
So it's a lot of this is a pulse check. I think it's really important to remember, in previous administrations, where civic engagement actually is built into what they called at hhs.gov, Healthy People 2020, Healthy People 2030. Civic engagement is what we consider as social and structural drivers of health. And so, yes, I totally agree with you. Our work is in addition to that is to saying, hey, are you registered to vote? And if you said yes, then is there a way for us to check to make sure it's still valid? And that is part of the work. I think it's also important to understand that folks who are who receive Medicaid or Medicare or fixed income type of insurance based that how they get their health and health care tend to move more due to many reasonings of being priced out of their zip code. Where are they going? And so we are very cognizant of that on the primary care level, really because that's part of the work that we understand. Sometimes people don't see us because they had to move due to other things. And so, we really focus on the fact that health is in all policy. I think it's really critical to understand that whether it is foreign policy, domestic policy, housing policy, economic policy, climate policy, it affects health. Health is really, by definition, anything that makes us human. And so I think, so being a social medicine physician, we focus a lot on that component. And when you think about it through the lens of justice, it is imperative that we follow through on making sure that folks, we see them and we hear them and understand that their power really is in the voice, though it doesn't feel like it is right now. And that's by design. And so we are really pressed on really making sure that we can have folks through this campaign be a part of the voices to champion that civic engagement is really critical to their health, their family's health, and their community. And so, as you said, are you registered to vote? But really also let's check to make sure that you still are a valid registered voter.
Thank you. This is really, really delightful. I am a certified registrar in Virginia. So we are getting ready to ramp up a voter registration program through the Black churches because, again, they see people every week. They're there. Well, bring a computer, bring a tablet, make sure that every one of your congregants is their registration is up to date. Yes, this is really where they live because where you live determines in most states where you're going to vote. So, yes.
Yeah.
Oh,
So for, I'm in California and, immigration policy is also a health issue. And, I take care of a lot of families who are what we would say mixed status families, meaning some are US citizens and some are not. And what has been very moving for me have been DACA students and DACA kids who really have been pushing for folks who are US citizens within their family to also go and register to vote. I think it's really important that we understand that, this election season, midterms, is really critical to how we think about the future of our country. The things that have occurred with the bills, have very detrimental effects. I'm seeing it every single day, and it hasn't really it's just getting started, if you will. And I think that, this is our opportunity for the future of us to be able to take it back, and being able to also really build healthcare in this country in a way that it's a right and not a privilege. And that comes with, from the first step of registering to vote, getting the folks, if you can't vote, then who do you know that can vote? Get them to go and register to vote, and then have them make sure that they have a valid registration, and then being able to go to the polls. Things are by design right now to make sure that you have voter suppression in this country. You've been here before, as you know. And so, here we are. This is a moment for us to be seen and heard in ways that really matter. And the special election showed us that in last November, that were happening across the country, and now for this midterms.
Virginia showed us that as well. So, Virginia, we had a great election. All right, we're going to bring Edwan back because Edwan's going to talk about the things that he has been working on to provide information for what your state can do to mitigate what's happening. And then I will also be dropping in a link for a brand new section of our website that we just produced, literally with the information that Edwan has built. So Edwan, go ahead and take it away.
Thank you. I was gonna say I did see some questions in the chat, and I wanted to answer those really quick.
Alrighty.
$1.3 trillion time period, that is until 2034 for that question. And then is it tied to the triple B? It is not, because the Build Back Better has not passed. And so that it didn't take into effect or account any of that. And then someone said, is this similar to the Sabuka, similar to what Massachusetts did in 2024? Yes, it is, actually. It is literally one of the model templates of what that looks like. I think that a lot of states are going to start duplicating it. I've already started playing around with it myself for Virginia. So, and then who else did I have for this? Yes. Oh, SAVE Act is still sitting in the Senate. It will not pass the 119th Congress. I promise you, it won't. I don't see it passing without bipartisan support because that filibuster is an inevitability. I think those were all of the questions. But to get us to where I really wanted to guide us to, which is some of the solutions. There were a couple of anecdotes that I did not mention to you guys before. The average travel time for emergency situations would have doubled or tripled. So instead of it being 15 minutes. Now it's going to exceed anywhere from 26 to 38 minutes. And then for the level of the amount of hospitals that will actually close or that are at risk, there's over 700 hospitals nationwide that are at risk. 300 are considered at immediate risk right now. And a little over 100 of them have already been closed. But solutions. So the big thing for me with solutions has always been focusing on the states, and allowing the states to utilize the autonomy that they currently have, to kind of help kind of mitigate some of the blowbacks from what this is going to look like. Every single state, no matter, like I said, regardless of where you are and what state, no matter how big or how small or how many people, is going to feel absolute effects from this, like without fail. And so the big thing for me is I really want to try and figure out like a state impact map. Of course, state impacts aren't uniform, and so they will all kind of hinge around what the situation is in particular states. I like using Georgia as one of those examples, because they have what's called pathways and not actual Medicaid expansion. And so it's really trying to decide what that's going to look like for them to pivot into even having an expansion of Medicaid that's actually doable for people across their state, and then trying to even put forth the efforts to try and put forth something like a statewide universal health care bill, right? The bigger thing for me with the impact is understanding where Medicaid expansion status and enrollment pressures are, how state finances Medicaid generally, which Georgia does not do a good job because Brian Kemp hides federal dollar spending. He always has, even though it makes up 33% of Georgia's total budget, which I'll never understand that. But figuring out the rural hospital mix and the payer mix, and then of course trying to get away from the marketplace reliance. We've been relying very heavily on insurance companies for a very long period of time, since the days of Richard Nixon, and I feel like between him and Kaiser Permanente, we have been kind of doomed to the healthcare system that we currently are facing right now. And there is a way away from that. We just have to be okay with being uncomfortable with what we've gotten used to at this point. And so HR1 does set the federal conditions, but states definitely still get to decide whether the damage is either absorbed by patients, hospitals, or the state budget. And so that's where you navigate the best. What states I think what they should watch for right now, honestly, if I was talking to anyone in their general assemblies or the governors, I would say enrollment losses are one of your biggest things. It's driven by work verification processes and whatever you can do to mitigate the paperwork kind of flailing that has been going on now to prevent people from falling off. That's one way to make up for it. A provider tax / like financing constraint, because there's not going to be money to be able to facilitate doing that. So it's trying to find ways to be more fiscally savvy and what that looks like. And making sure we create tax revenue of some kind, whether it be from charging other people more money, of course, companies or what have you, like Chuck was talking about, and trying to figure it out that way. Or even like the delaying of eligibility simplification rules. So states can't count on federal rule-based burdens at all. Just codifying those things and those exemptions now will prevent the blowback later. Some legislative remedies, protecting coverage, protecting hospital package. This is kind of the meat of it, right? So here are the remedies that are like very state legislature oriented. Coverage retention and churn control, which is making sure people are staying on the service. Express lane eligibilities to auto renewal, so making it easy to do the auto renewal instead of relying on the old ways of doing it. A 12-month continuous eligibility clause, because I believe it's 6 months right now, which will break down into quarterly once we get to the end of all of this. And then state-funded enrollment navigators and legal aid to target renewal denials and administrative errors, to kind of help navigate that as well. So, HR1 does increase a lot of pressures in that regard, but states have to build the retention infrastructure. Because if we don't build it, they're not going to build it for us, and they want us to not do that. Some rural hospital stabilization bills, which are really the core protections for all the rural spaces and places. Utilizing the stabilization fund, prioritizing those coverages that will be lost. So like OBGYNs, ER staffing, some behavioral health and crisis services, and things like dialysis and oncology. Excuse me, global budget and rural emergency hospital critical access support. So, this is done through the state, of course, through state statute and Medicaid plan actions where feasible. So utilizing the state dollars and the federal dollars to solve that issue generally. And then a lot of workforce support. So loan repayments, residency rotations, and making sure EMS stabilization is tied to keeping service lanes very, very open. So, rural losses are large, very, very large relative to where the health fund coverage is going to like actually try and cover things and services. And so states are still going to have to put their hat in the ring when it comes to making sure that rural areas in their states are taken care of. I saw a question in the chat. When states expanded Medicaid, ACA brought revenue to states. Correct, it did. So the impact funding law, yes, we will take blowback from that. 1,000%. Because ACA requires premiums to still be paid is in a marketplace style form and create another pool of funding, right? Even if you're putting into that, if they take away the federal dollars that like help compensate a lot of that, that means that people have to take the brunt of the cost, and that's the cost that I know I can't afford, and I'm sure that a good 75% of us can't afford. And but for what they're asking for, and the only entity that can, honestly, is the federal government. But it's finding those financing backstops. It's hard, but it's decisive. You've got to put up restraints. You've got to match dollars down. You've got to put up tax caps on people who make the most money. You've got to find a way to rebalance and shift the money around to get the directed payments taken care of, and building on state maintenance, and to make sure that those hospitals can still maintain through and weather every storm that comes at it. I think the bigger thing is providers are already, warning rural grants, and that won't cover the structural Medicaid. We know this for certain. And so in some states, it's going to be mandatory for the states to really step up and actually meet them where they're at. Because if not, they're going to risk losing it. And once you lose it, it's really hard to get back. And then marketplace, we were talking about the affordability protections. Create a state premium assistance for low-income enrollees, maybe. Fund reinsurance, so strengthening existing programs to lower premiums. Expanding outreach to keep making sure people are keeping their coverage. Navigating this politically, honestly, don't argue ideology. I will start there. This is not about, and I've said this to Republicans and Democrats and 3 states now at this point. This is not a Democrat problem. This is not a Republican problem. And depending on what state you're in, that is the respective issue that it is. If I'm a Virginian, it's a Virginian problem. If I'm a Georgian, it's a Georgian problem. If I'm in North Carolina, it's a North Carolina problem. So, we can't cut our way into the access. If the hospital's closed, a lot of times, a lot of counties and full economies will fall. And so we have to be really understanding of what that looks like. And the workforce development and public safety things that are really tied to that also play a major factor in that, honestly. We know hospitals also host folks for beds a lot of times. I know I've seen multiple homeless person on a cold night be okay with checking into the hospital, make sure they had a place to sleep. And so, using the rural vulnerability situation is definitely a human anchor, especially for a lot of conservative facing legislators. Quick close for me though. HR 1 really drives up uninsured and drives down Medicaid dollars. So the policy choice at the state level is really whether to let that translate into closures and coverage loss, or whether to legislate retention, stabilize the rural systems, and really, really focus on protecting access. The site for HR 1 is up. I have covered in those dossiers, I cover all of the big things for each state, I would say, honestly, to their individual situations. I know for Virginia, we were looking at, I did it for every state: tax conformity, Medicaid and Medicare coverage, hospital closures and the effects of rural areas, particularly, SNAP and EBT focus as well. And then focus on education loans, college education loans, and loan protection for folks for education loans and grants. And then, of course, each state has their own individual legislative package to kind of figure out and navigate what that looks like. The only bills that have been done right now have been for Virginia and Georgia, which Georgia had picked up a couple of them as well, which is Lode. You and I should have a deeper conversation about that with Georgia, because me and Dr. Monica Brown need some help with the Legislative Black Caucus and trying to herd cats in that regard. But I think that if whatever state you're in, please look at it. Please take it to your legislator. Please take it to your state houses. Please give it to your governor. Give it to your representative, your state senator. Hell, give it to your local city council person or board of supervisor. Whatever constitutional officer is willing to pick it up and talk it to another one that can actually do something about it, do it. They need it. Any nonprofit that's willing to have the conversation, do it. They need it. Because if not, it's not going to be a pretty sight for anybody. And like I said, I covered every single solitary state, even the little ones, and because those are going to be the ones that take the hardest hits. It really is. Losing a hospital in Connecticut it looks real different by comparison to losing a hospital in, say, Virginia, just because of the size of the state itself and who it's covering and how many people is actually in its bubble of coverage. Oh, each state is broken down based on their individual situation where they are with ACA. There's a legislative package attachment. A good amount of them have like messaging attached to it as well, to how to lobby it for your legislators, as well as for them to lobby it to their fellow legislators. Because again, this is all, we know it's coming. It's one of the few times we actually have an advantage of the situation, because we know it's coming and we have to do something right now. Literally, we've got until maybe 2028, maybe. Alabama's already feeling effects. We were talking about that on Tuesday. They started feeling effects January 1. So it's not going to, and their governor's allowing it. And so it's not going to be long for other states to start really feeling the blowback and what it looks like. But I appreciate y'all. I appreciate your time. I appreciate y'all hearing me out. And I hope we can take steps forward together, and whatever that looks like, please do not hesitate to reach out to me to do that. I mean that. I told Andrea the same thing. If I got to get each one from all 50 states into the state house my damn self, I will travel the entire country and do it. It'll take me about 6 months, but I'll do it.
Thank you so very much, Dr. Sharma. It was fantastic getting to meet you. You and I, we will talk. And
Thank you.
Thank you for joining us, even though you had had such an incredibly difficult travel day. Now, I know the information, especially the information that came from Edwin, was literally like drinking from a fire hose. So as I said, the presentations that were given, you will also receive a recording of this meeting. There were a number of questions in the chat about ending corporate rule. How can we stop big corporations from buying hospitals? How can we stop big corporations from buying residential property? Well, we really do have a solution that does not require that we pass a constitutional amendment, since corporations are products of a state. They are incorporated in a state, and that state has the ability to tell a corporation what it will do, what it won't do, what it can do, and what it can't do. The state, when they grant corporate charters, simply need to say, as a corporation, you cannot buy a hospital. And so, again, that's much easier said than done, because now we have hospitals becoming bad actors. In Virginia, many of our big hospitals have non-compete clauses with their doctors that say you cannot practice medicine for money or for free within 50 miles of our facility. And they define their facility as anything that's got their name on it. And so, in predatory fashion, they are going out and buying up stuff in rural America. As long as they've got one thing with their name on it in some rural county, well, you got to be 50 miles from that. So, now really is the time that we have to think very hard about how we will be reining in these corporations, the big baddies that we know about, preventing others like hospitals from becoming bad corporations. So these will all be things that we will be exploring in future meetings. In Virginia, we already have a bill. It is called the Corporate Reset Bill that comes in and defines what a corporation is and what it can and what it can't do. And one of the things that a corporation will not do in this bill is they cannot contribute to political campaigns and candidates. They can't.
Yeah.
You're not a person. No, you don't have a vote. No. So thank you so much for joining us tonight. You will get the website. You will get Ed One's contact information because he is always delighted to work with people and help people. So thank you all so very much for joining us tonight. I am stopping the recording now.